really sorry, guys. Oh, we are live now.
So I can go.
She just needs to get this link. I'm really sorry, guys.
Okay.
Oh, we are live now. Okay. So send her this link. And I will let you know when she's watching.
Again, just tell me to go or when to go.
Okay. Did you send that to her?
Mm-hmm.
All right, waiting for her to get to it. Okay, it looks like we're good.
Okay, so I can go.
Yes.
Okay. Hello, everyone. Thank you for watching this informal debate. I am Megan Williams, and I'll be your introducer. Other members of this group include Emma, who will be the summarizer for the pro side, Lauren, who will be the summarizer for the con side, Alex, who is our illustrator, Gwen, who's our researcher, and Ashley, who's our fielder. Our topic covers whether or not evidence-based practices should be standardized and if it is ethical. In this debate, we will be exploring what evidence-based practices include, the impact on individual outcomes, the ethical implications of standardization, parental choice, social validity, and then the limitations of current research. For starters, we'll define what evidence-based practice is. What are evidence-based practices, or rather, what do they include?
Most individuals consider an evidence-based practice to be any treatment that is replicated at least once by a separate researcher than the original researcher, with the same results given an independent randomized research design.
So are there practices that have been deemed evidence-based?
There are practices that have been deemed established treatments. These are based on the National Standards Report and include antecedent package, behavioral package, comprehensive behavioral treatment for young children, joint attention intervention, modeling, naturalistic teaching strategies, peer training package, pivotal response treatment, schedules, self-management, and story-based intervention package.
Okay, so I guess my next question is, what is standardization?
Standardization is the process by which all evidence-based practices are evaluated. This means that these treatments have met specific criteria to be included as an evidence-based practice, and that these criteria are the same across the spectrum of treatments. Basically, here's the rubric we're going to use to give a treatment the name of evidence-based, and we think that all treatments in use need to be tested against this rubric to determine the quality of treatment.
And why do you think these treatments should be standardized?
I think one of the biggest gains is that it would close the gap between research and practice. And Reichow, Volkmar, and Cicciotti agree. We know these treatments are working, and now we're carrying out the treatment in clinics where people can easily access the treatments instead of simply being able to read about the treatments in a laboratory setting. In the same study, the authors also found that it reduces the time that practitioners have to spend researching evidence-based practice because it's already laid out for them. Instead of practitioners having to dig for the treatment, they're all listed out with their levels of efficiency. Now, practitioners can choose the one that best fits their client's needs. Also, as seen with the 2005 Timmermans and Mock study, Without systematic guidelines, standardization is not possible. And evidence-based practice becomes indistinguishable from any other treatment, evidence-based or not. The reason we need standardization is to present these treatments as the treatments with the most evidence supporting their use.
Okay, now I understand. That seems like a pretty good idea. Why wouldn't someone want their treatments to be standardized?
Well, in the study by Timmermans and Mock, they found that some individuals are worried that standardization takes away professionals' experience and leads to a one-size-fits-all approach. In other words, practitioners would simply be prescribing the same treatment to everyone because it has the most research behind that treatment, instead of looking at individual differences. I have to add that Timmermans and Mock also found that even with standardization, some practitioners have not heard about evidence-based practice and continue to use their own systems and treatments. This is harmful because it means not all clients are getting the same standard of care.
Now our group's going to discuss individual outcomes. So would you say that evidence-based practices are important on the individual level?
I would say so, yes. Evidence-based practices are the best way to ensure that the treatment given to an individual is the highest quality and the most likely to work.
I think it's important to note that most likely is the key phrase you used.
What do you mean?
Well, are there any practices, whether they're evidence-based or not, that have a 100% success rate?
Of course not, but by meeting a burden of being evidence-based practices, they have significantly testable and verifiable success rates. And while it may not be a perfect treatment, by passing this burden, it is proven to be the most effective in the most circumstances.
To be considered effective to the evidence-based standard, a treatment has to be shown to have a correlation to the outcome.
Correct.
And it has to beat the placebo effect.
Right. Beating the placebo effect in any field of research is important to ensure that the treatment is having a significant effect outside the positive effect of a subject's expectations.
So a placebo is when someone expects something to work and the outlook and the brain are able to produce positive results, even when no real active proven treatment is taking place.
Yes, it is most common in the medical field with medications and such.
But it has been shown, notably by Sandler in 2005, to take effect in other fields too, even in the treatment of developmental disabilities. Even when a subject is not cognitively developed enough to understand the implementation or the expectation of a treatment, caregiver and environmental expectations could yield a positive result in what is called the placebo by proxy. Evidence of these indices can be found in Whaley and Hyland's study from 2013.
But the rates in which the effect of placebo and placebo by proxy are significantly lower than those of evidence-based practices.
That's true. Positive placebo effect is a much lower rate than those of evidence-based practice. Given that in many studies, the placebo effect is when a treatment is setting out to beat, it's specifically designed to outperform the effects of the placebo alone.
So wouldn't you agree that since evidence-based practices are proven to beat the placebo effect, they should be the standard in which to hold all treatments as effective? With this standard, there would be less of a chance to provide a treatment that just won't work.
Although, as you said yourself, no treatments are 100% effective. And while alternative treatments may have a smaller effect for fewer people, there is a chance that there would be a situation where an established treatment is not effective, but an alternative treatment or a placebo would be. An individual's outcome may be neglected if their practitioner isn't able to use a practice that may have previously provided a placebo effect, and instead the practitioner is only focused on using a more evidence-based practice, which isn't even yielding beneficial results.
Okay, I see what you're saying, though even if there were a case like this, it would be our duty to conduct a single subject design to see if in this case, this alternative treatment was in fact making a difference contrary to well-established data.
Granted, it'd be important to do that kind of testing, but with a standardization of evidence-based practices, would it be possible to consider these outlier cases and provide the most effective methods of treatment for everyone?
Maybe not, although it also protects against people falsifying these kinds of results to promote their own treatment. In a study in 2016, Shrek, Karunaratne, Zane, and Wilford found that even among BCBAs, there are practitioners that list unscientific, unproven, ineffective, and sometimes potentially harmful treatments against their preferred treatments. If these kinds of treatments are permitted under the guise of a case-by-case basis, we are not serving well the individuals that fall in with people promoting and practicing these techniques.
Both of you made some pretty good points. Now we're going to move on to the next topic, professional and ethical issues and dilemmas. Would you say that standardization of evidence-based practices will assist practitioners in making professional and ethically based decisions when selecting the most effective treatments for clients?
Yes, standardization of evidence-based practices will guide professionals in selecting the most beneficial intervention that fits the client's needs.
I think this depends on whether a practitioner understands their limitations regarding their scope of competence. For instance, a practitioner may select a standardized evidence-based practice that fits the client's needs, but that practitioner may have limited experience or knowledge regarding that particular intervention.
Right, but it is the responsibility of the practitioner to adhere to the professional and ethical compliance codes, PECC, for behavior analysts set by the BACB.
Absolutely, I agree. However, standardization of evidence-based practices has the potential to lead to more violations in PECC Code 1.02, Boundaries of Competence.
How so?
Well, this code states that the BCBA will apply treatment as long as it falls within their knowledge or their expertise before they're implementing. A standardized evidence-based practice may be outside of a practitioner's scope of knowledge, but that practitioner may decide to implement it without seeking the research, training, or the experience they need to apply the intervention in practice, which then creates a significant professional and ethical dilemma. So standardization of evidence-based practices may not always result in the most effective treatment for a client if it doesn't fall within the BCBA's scope of competence.
Right, but you also have to consider that standardization of EBPs would help eliminate the use of interventions that are not empirically supported and not within a behavior analyst's area of expertise. This can include the use of complementary and alternative treatments like the gluten-free diet. Kasdan, in an article, highlights how resources have become more available to practitioners to help make EBPs more accessible and promote the implementation of these treatments.
This is true. Essentially, professional and ethical dilemmas will arise if the BCBA doesn't follow the PECC appropriately when deciding on an intervention and which one to implement. So a BCBA must seek continuing education opportunities along with other resources before applying evidence-based practices that could suit a client's needs.
Which is why the PECC exists as a way to help prevent and guide practitioners through professional and ethical dilemmas when practicing in the field of applied behavioral analysis.
Slocum et al. In 2014 mentioned that there's a gap that exists between research-based evidence and what's applied in practice. Additionally, Broadhead et al. In 2018 discussed how there's a potential risk of practicing outside of competence, which falls under the responsibility of the professional.
This is the responsibility of the professional to maintain competency and be up to date on EBPs and seek continuing education. Raghavan et al. In 2008 discussed how evidence-based practices help to ensure that the client is receiving the best available and beneficial intervention. Also, Copeland and Book in 2013 discussed that evidence has supported that behavioral interventions are most effective when based on evidence-based strategies. So that supports that standardization of EBPs would ensure clients are undergoing treatment that has been demonstrated to be effective in changing a target behavior. This can help to increase the quality of services individuals and families receive. So standardization would assist behavior analysts when deciding which treatments to choose as they have been empirically supported.
Correct. I agree. I think the ethical issue lies in whether the evidence-based practice selected and implemented falls within the BCBA's scope of competence, as I mentioned, which could influence how effective the treatment is in changing the behavior.
PECC 2.09a, Treatment Intervention Efficacy, mentions that EBP decisions require expertise, which is also discussed by Slocum et al. Therefore, the PECC would help prevent the potential risk of BCBAs choosing standardized evidence-based practices simply because they are standardized by guiding them to seek the appropriate resources, analyze the client's behavior, plan intervention procedures prior to implementing a standardized treatment option.
Yes, the use of EBPs is emphasized in the PECC. Standardization would drive practitioners away from using non-evidence-based practices, such as complementary and alternative medicines, which, as Lofthouse et al. Pointed out in 2012, can have irreversible or dangerous side effects. As you mentioned before, the gluten-free diet could have dangerous long-term and even short-term side effects for clients. It could affect a student's academic performance on a day-to-day basis, or even have long-term health risks such as nutrition deficiencies. However, there is an ethical issue that's created surrounding practitioners who choose standardized treatments.
What is that?
Well, is it ethical for a professional to deny using an evidence-based practice if it fits the client's needs, but it has not yet been standardized?
I would say that this applies to PECC 2.03 consultation. Again, standardization of EBPs will help guide practitioners in deciding what intervention to implement. But it is also important that the practitioner follows PECC 2.03 and consults the client and caregivers in the decision-making process, as all interventions must be evidence-based, but have to be approved by the client and caregivers before implementing.
Right. Standardization would mean that BCBAs must act professionally and ethically and consult the client, as you mentioned. Copeland and Butch agree in their 2013 article. Just because it is evidence-based doesn't mean it's the only treatment option, especially if the client or parent does not approve or asks for modifications.
Yes, informed consent obviously needs to be obtained regardless if a treatment is evidence-based or even becomes standardized. I want to mention how Callahan et al. In 2008 indicate standardization of evidence-based practices could even occur across settings, which could further increase social validity, including those that take place in various settings, such as working with school staff or parents. This applies to PECC 4.03 Individualized Behavior Change Program Objectives and also 4.05 Describing Behavior Change Program Objectives. Standardization of EBPs still allows for modification to treatments to ensure that the treatment is meeting behavior change objectives that fit the client's needs. Also, the BCBA can still adhere to the PECC 4.05 by justifying the use of the selected treatment by describing the behavior change intervention goals.
EBPs are not one treatment fits all, and therefore modifications must be made to individualize a treatment for each client. A behavior analyst must consider functional assessments, the environment, the client's age, who is going to be implementing the treatment, so on and so forth. Therefore, when selecting a standardized evidence-based practice, a BCBA still needs to consider all of these variables.
I agree. One treatment does not fit every client exactly. Modifications need to be made in order to individualize treatments. It is the behavior analyst's responsibility to adhere to these codes.
Correct. The standardization of EBPs will be beneficial as it will serve as a tool for behavior analysts to choose interventions that suit the client's needs.
Both of you made some valid points there. We're going to now move on to the next topic, parental client choice and social validity. Speaking of intervention choices, how will standardization impact parental client choice and or social validity?
Well, at the very core of our practice is the Professional and Ethical Compliance Code. Following this code is an ethical obligation in and of itself. The PECC contains codes 2.098 and 4.02. These codes state that clients must consent to and be involved with planning treatment and that clients have the right to an effective treatment. In this field, the definition of client also includes parents or caregivers of the individual receiving the treatment. These ethical requirements mean that choice and support, social validity, from the parents and or caregivers is a critical and ethical obligation. EBPs require a minimum degree of social validity in order to receive the label of evidence-based practice. Standardizing these practices ensures social validity is inherent to the treatment options available for clients.
I think it's great that you point out PECC Code 2.09a regarding the client's right to effective treatment, as I feel this is extremely important. However, Shepard et al. In a study in 2017 found that parents rejected EBPs and did not feel that they'd be an effective treatment. They found instead that the factors that parents found most important when selecting a treatment included access to the intervention, the perceived cost, and the availability. Cost and access were the most important considerations for parents when they were considering treatments. Their research also found that limiting treatment to only EBPs would mean that the more cost-effective and easier to access treatments, which could potentially still help the client, wouldn't be available. These include speech therapy and occupational therapy. This is in turn a direct violation of PECC Code 2.09a.
I can understand how limiting access to other treatments seems detrimental. However, another study in 2008 by Callahan et al. Collected evidence reflecting attitudes of teachers and parents that stated EBPs were seen as very important or absolutely important for effective autism programming, indicating high social validity and ultimately leading researchers to believe EBPs are more prominently considered in the first place.
An excellent example of acceptance, sure. But what Callahan et al. Also found in that 2008 study was that several interventions associated with the evidence-based practice of ABA were ranked in the bottom quartile for parental acceptance. This indicates a significant disconnect about the degree of social validation between research, training, and the practice of EBPs. In short, the level of social validation claimed may be acceptable, but it may be skewed.
PECC 4.02 means we must include clients in the planning and treatment decisions, and familial cooperation can go a long way to aid in success. Comfort and relief can be provided to families and clients if we standardize. Standardizing EBPs ultimately means easier decision-making for parents. This is incredibly important because, as Shepard et al. Found in their 2017 study, when clients are looking for treatment, they are given freedom of choice, and consequently, they may become overwhelmed because they are bombarded with a plethora of intervention options and conflicting information about what is the most successful treatment. This may cause families to seek other illegitimate treatment options or no treatment at all.
While standardizing EBPs would somewhat simplify the decision-making, it would still require families and clients to do a lot of research to help choose the best one. Parents do not utilize this avenue of real research to make a decision about treatment. Instead, Shepard et al. In 2017 found that parents utilize their gut feelings, their intuition, medical personnel, family, friends, and the basic internet. Expending the effort to standardize EBPs is a moot point when parents don't pay attention to the research supporting them in order to choose an appropriate treatment.
Lastly, our group's going to discuss limitations of available research. With regard to evidence-based practices, do either of you find there are limitations within the current available research?
There are definitely limitations. That is just a part of research as a whole. However, standardization will help with the inconsistencies that are seen throughout research with the implementation of other researchers' methods.
I think it's also important to think about it from the other side, in that if there hasn't been enough research done, how can we actually standardize a treatment? According to studies done by Ellis et al. In 1995 and Geddes et al. In 1996, evidence-based practices were being implemented with less than half of the clients or patients. And of those patients, none of them were getting it consistently. Therefore, we're lacking clear research on the effects.
I see where you're coming from, but this also makes me more adamant about standardizing evidence-based practices to ensure that they are being infidelity.
EBP by design is already somewhat standardized in that it's guided by the best available research. A concern of standardizing more formally would be that countless studies that have been made replicable perhaps would be deemed insufficient, and we would lose valuable research. I have to believe that trials with some limitations are better than no research at all. Would you agree with that?
I can understand that viewpoint, and I do not disagree that it would be unfortunate to lose a great deal of research because it wouldn't fit within the standardization process. But if there are things that don't work or invalid, would that qualify as an EBP?
And I think within research, this is how we learn and grow. When gaps and limitations are found, it creates opportunity to further study those interventions and continue with the scientific cycle of research, which then in turn can produce further interventions and allow for more opportunities to help a wider variety of individuals. If we were to standardize EBPs, we could lose many opportunities for the research of new and additional treatments. I do think it's critical to note that the National Autism Center in 2011 shared that even though evidence-based practices are supported by many people, they are not supported by scientifically sound research. And this makes it difficult to know which treatments have research that show effectiveness and which do not.
True, and this is another reason standardizing evidence-based practices is important to ensure that the research being done is scientifically sound and can be trusted as sources of information for those trying to determine the best treatment for an individual and their family or for the client that they work for.
Yes, and I would have to say that standardizing EBPs may make the research process too rigorous then, and it in fact could deter further research, which defeats the whole purpose.
If standards were created, however, researchers would have better guidelines and therefore would be able to potentially save time.
It's important to remember that there is a delay from the time of research to translating them into practice. So if we are also to delay this research further by needing to standardize it or ensure that it fits within the standardization, more time would be lost. And again, I believe that this would deter some researchers from following through with their desire to try something different or new.
Okay, so research is clearly critical as it relates to evidence-based practices, and it is critical that we consider the availability of quality research when determining a need or ability to standardize evidence-based practices. In conclusion, the ethical code continues to be a driving force for going forward with standardization. BCBAs have a commitment to provide effective treatment within their professional boundaries. The overreaching goal of standardizing evidence-based practices are to offer treatments that have a proven track record and have been shown to improve the quality of life for clients. As for future directions for evidence-based practices, researchers need to continue to work to move from research to practice and to disseminate their findings to practitioners, along with creating unified definitions and monitor the implementation. After completing all the research and looking at both sides for pro and arguments against standardization of evidence-based practices, our group supports standardization. Now we'll discuss some frequently asked questions.
Will standardization result in more limited scope of knowledge and intuition of practitioners?
Standardization may limit the scope of interventions explored for treatment, but it's important to distinguish the fact that the scope created is one that's pointed directly to treatments that are evidence-based practices, which, as discussed here, are treatments that have significant, testable, and demonstrable success rates. Standardization means that practitioners need not waste their own or their clients' time and resources on finding and trying something that shows no evidence of even working. In addition, our PECC identifies the ethical obligation to treat clients with effective methods using treatments based on scientific knowledge. Standardization helps us ensure these ethical guidelines are met without a worry.
Will standardization of evidence-based treatments reduce the number of ethical dilemmas practitioners face?
The PECC contains codes that are required or that require practitioners to utilize treatments that are effective, science-based, and socially valid. So the act of standardizing treatments means these ethical obligations are fulfilled, which makes it nearly impossible for them to be violated. In addition, ethical obligations that require practitioners to communicate treatment with clients, obtain client consent, and report progress to clients and third-party providers are greatly simplified through standardization. Standardization further means treatments are empirically supported, which also makes it easier for clients to understand, thus easier for them to consent to the treatment options. Third-party providers such as insurance companies can be confident that their aid is going toward treatment with evidentiary proof of success. In short, yes, absolutely, standardizing EBPs reduces ethical dilemmas.
Will standardization of evidence-based practices help BCBAs adhere to the professional and ethical compliance codes for behavioral analysis?
Yes, it will. In conjunction with the previous answer, it will simplify requirements and greatly reduce or even eliminate the chance to violate some of the ethical codes presented in the PECC, such as codes 1.01, 1.02, 2.09, and 4.01, some of which we talked about already. These codes emphasize the importance of using treatments consistent with behavior analytic principles, providing the most effective treatment to clients. Treatment should be within the scope of a behavior analyst's practice and based on science. So standardizing makes it easy to align with these codes and helps ensure professional and ethical conduct in the field of behavior analysis.
Will standardization of evidence-based practice help bridge the gap between science and treatment?
Absolutely. We already know evidence-based practices exist in research, and now they're starting to be applied in real-world settings, which is a huge step in the right direction. Standardization means there will be more fluid understanding and application of EBPs in settings such as the clinic, the home, or an education center. Practitioners will have to spend much less time reading and researching, as standardization means treatments will already be easily available and explained. Also, when practitioners are utilizing EBPs, it means they're using treatments that have demonstrated success. Using EBPs in real-world application means even more success in those settings, which ultimately bridges the gap between research findings and real-world application by providing further research that these treatments work. Building the evidentiary support for EBPs will further help create guidelines for future treatments to be developed, thus ensuring they have the highest likelihood of success. Then we can arguably be confident that that between science and treatment, there will be almost no gap.
Will standardization conflict with a parent or stakeholder's choice if they want to try or include alternative methods?
Standardization could conflict with parent and stakeholder choice, yes. However, it's important to understand that standardized treatments must meet a required level of success in order to be labeled an EBP in the first place. Now, suffice it to say, success is a primary concern for treatment approval, selection, and maintenance. Due to their nature, standardized treatments are the best way to answer this concern. One could even argue that maintaining parent and stakeholder choice for alternative treatments is actually the unethical and detrimental route, especially when the alternative treatments explored are not scrutinized to the degree that standardized EBPs would be. Exploration of alternative methods could lead to serious treatment interruption, and although, again, parental choice is important, it is our obligation as behavior analysts to guide them to and encourage them to choose treatments that are most likely to provide the success that they're looking for.
How can we define evidence-based practice to better determine a need for standardization?
Well, there are several definitions of what constitutes evidence-based for a particular treatment. McGrew, Rubrel, and Smith in 2016 call for standards of 5 separate single-case research design studies that are replicated in different locations and in which there are at least 20 participants. While others, such as Reichau, Volkmar, and Cicciotti, state that there must be 10 single-case research design studies replicated in 3 different locations and with at least 30 participants, as well as some requirements that may be based on a group design or a combination of group design and single-case research design. But by creating a common definition of what constitutes evidence-based treatment, whether or not a treatment is in fact evidence-based simply on the research criteria that was used. It can also make applying the label of evidence-based in research or applied settings easier and more common. I would even argue that creating a common accepted definition of evidence-based is the first step in standardization. We are attempting to standardize what constitutes evidence-based practices, and if we don't know what that includes, we can't take further steps for standardization.
Will standardization increase social validity or positively impact parental choice?
By allowing parents to access treatments that are standardized as evidence-based, they will have control over choosing what treatments they want to pursue for their. Standardization starts with defining what evidence-based practices consist of, and then ensuring that stakeholders, such as parents, have access to these treatments and their components. In one study by Callahan, Henson, and Cohen, parents held the opinion that access to evidence-based practices in a public school setting were very important. Having access to evidence-based practices that have met the process of standardization increases the options that parents have, as well as putting them in control of choosing the treatments their child receives, because the parent is better able to understand what it is that makes that treatment.
Are there interventions that have been demonstrated to be effective that are unethical?
There are certainly interventions that are effective that are also unethical. The first that comes to mind is the seminal study by Dr. LaVos. He utilized punishment as an effective way to change behavior. Now, to be unethical. This connects to PECC codes 4.08 punishment procedures and 4.09 least restrictive procedures. Although punishment is effective, behavior analysts are committed to the principle do no harm and must take into account the effect that procedures have on an individual, such as their mental, emotional, and physical health. Other things to consider include the types of reinforcement that are being offered to dangerous or ineffective. 3.10, avoiding harmful reinforcers. By utilizing the PECC, behavior analysts can make ethical choices while also providing effective treatment.
If the vast majority of interventions involve more affluent, educated, and white participants, is a treatment in reality evidence-based for clients who do not fall under these demographics?
It is true that due to cultural differences, some interventions do not work as well for individuals of different ethnicities. To remedy this, I think that replications of current evidence-based practices should be conducted with individuals of different ethnicities and socioeconomic classes. This is echoed by Carroll, Collins, and Lusk in their 2017 study. They did a meta-analysis reviewing 22 studies of emotional behavioral disorders. 0.3 participants were white. This conflicts with the majority of individuals at risk for emotional behavioral disorders who are African American. This discrepancy in research and those in need of services highlights the need for ongoing research to determine evidence-based practices for individuals of different ethnicities. Perhaps these treatments are not evidence-based for minorities, but by standardizing evidence-based practices, one criteria should include that research is conducted populated.
Is the most effective treatment one that enjoys the most researched support, or is it the one that produces improvement because it can be implemented with fidelity or the length of time needed to produce such behavioral change?
I would argue that a treatment that is implemented correctly and produces effective behavior change should also be the one with the most research support. Replication should be conducted often, continuing to support the treatment. The established treatments mentioned earlier are treatments that have much research to back them up, as well as producing improvement because they can be implemented with fidelity. Another thing that researchers should consider is conducting replications within more practical environments, such as schools and clinics, to determine if individuals outside of research can produce similar results and retain treatment fidelity.
This concludes our presentation. Thank you very much for watching.